to this, and we are having Dr. Siris there, Dr. Suspa, Dr. Hori, we all faculties are there. If you are having any questions in between, you can put there, and Siris and the others will be there to answer your questions in between without breaking the interruption. But at the end, definitely we'll be taking all the questions, whatever is there for you. And after this part, so Suspa and me will be demonstrating some of the lumbosacral procedures. Lumbar important procedures we have discussed, we have demonstrated last day. Today we'll be talking about the sacral procedures, means sacroiliac joint, sacral nerve root, S1 nerve root, and caudal epidural. These are three things which we'll be covering today with the demonstrations on the mannequin. So this is the today's topic, what we are going to discuss, right? So again, today will be also based on Kahoot. So let us share the Kahoot. So quickly, you just, the login to the Kahoot. Okay, so campaign is on, and you quickly log in, and then we'll be starting the Kahoot based PPT. Meanwhile, if you are having some questions for us,
live
in your mobile, you need to have a second device. With one device, you cannot log in. So you should have a laptop and you should have a mobile. In your mobile, you just scan this one. This QR code is there, you scan it. Then you'll be entering there. Or what else you can do is, you can open the mobile browser and write this one, this www.kahoot.it. And it will be asking game pin. Once you are putting the game pin, it will be asking your nickname also. You see, so many people has joined with their nickname. You can put your real name, you can put your nickname, whatever it is. And then you are in. Once you are in, you'll be able to see your nickname here in this. Okay, understood? So this game pin you need, it is shown there. Or you can directly, just scan this QR code and you can log in. Logging is not mandatory, but you'll be enjoying, by participating the quiz at the end of the lecture. Okay, shall I proceed? Or anybody else is still trying? Okay, so anybody also can join in between, no issues. So you just need this game pin and you can join it without not having much delay. Let me start today's class. Okay, so just to have an idea that just participate in this poll. Let me see how much of you are doing the CM guided interventions on the patients right now. Just to have some quick idea about. It's not mandatory. I know that many of you are very new. You are not doing anything, but still, I just wanted to see. Okay, so never is 62%, right? Fine. So most of you are new. So now steps of evaluation. What is very important, why I actually had this poll, that intervention is not everything. The most important part in pain medicine or pain management is to evaluate a patient properly. Evaluate the patient properly. Try to understand what is the cause, what is the pathophysiology of the pain. Pain is not normal, no? Already we have discussed in the first class, there are a lot of things in the pain. So in the pain pathway, sensitization, modulation, how we discussed in the first class. So what is important to understand that why a person is suffering from pain, what is the pathophysiology going on, and what is the diagnosis behind these things. So back pain is one of the commonest reason, and here we'll be discussing about the different causes. Last day we have discussed it. Today what we'll be doing, we'll be starting with the red flags, what are the dangerous diagnosis, and then we'll be going ahead with other things as well. So what is the red flag for the back pain? Mild motor weakness, retention of urine, severe pain, mild numbness. Last day also we had this quiz, but again, repetition of the same quiz. So, unable to pass urine is one of the very important red flag, and immediate surgical decompression is needed for this patient. So, the mild motor weakness is not a red flag, severe pain is not a red flag, mild numbness are not a red flag, but unable to pass urine is a red flag. Remember that things. And we'll be talking about the red flag first, and then we'll be talking about the other things. So, these are the steps. Whenever you're evaluating, and not just for the back pain, for the other pain as well, these are the steps. So, what are the steps? Number one is what are the causes and what are the red flags? This is number one. Number two is in history. In the history taking, you should have a general history like all other patients, and specific history. Specific history means you'll be asking some specific question that, like for the back pain, is sitting aggravating your pain? Like this kind of some specific question which you'll be asking for evaluating the specific pain. So this is specific history. Then is the examinations. In the examinations, we are having the general examinations, general survey, we call it more popularly, like, the anemia, cyanosis, pulse, and all those things. So then your inspection, palpation, range of movement, all neurological examinations starting from the higher functions, and then lastly some special clinical test. Not all special clinical tests. Your special clinical test should be based on your initial evaluation. Like suppose you are thinking or suspecting a back pain leading down to the leg, it can be SI joint, it can be your radicular pain. So you should be doing this straight leg rising test, you should be doing all the tests for the sacroiliac joint, but you need not do some other test which is not that relevant. So special clinical tests should be based on your initial assessment. You should be choosing that these are the special clinical tests, you should do it to understand our diagnosis. And then some of the investigations, diagnostic intervention. Last day we talked, it's very important in the hand of the pain physician that whenever you are in doubt, we still have a dilemma. We can put some local anesthetic into the structure and we can understand what is the pain generator. I told you this term is very, very important for the pain physicians, is where is the pain generator. And last day also I talked about another important thing, that only where is the pain generator is not enough for our diagnosis. We have to have the second part of this question. Why this structure is a pain generator? Means what is the pathophysiological process? So these two questions for all different kind of pain we discussed last day. Today we'll be starting with the red flags. So these are the pain generators. These slides also I shared last day. So today we'll be starting with the pain generator. So the red flags. So red flag, one is the major trauma. Any road traffic accidents, any fall from height is always a red flag. It should be, red flag means what? Dangerous diagnosis. And there, so pain physicians should not be alone who will be evaluating the patient pain. It should be a team. There should be an orthopedic surgeon, a neurosurgeon, maybe a neurologist, maybe a physical medicines, maybe a pain physicians. All together, there should be a team. At least 2-3 people in facility should form a team and to examine this patient, because you might be missing something. The patient might be needing the surgical interventions. So you need to have a spine surgeon or a neurosurgeon in your team. Then, if you're suspecting any tumor by some X-ray or by some, suppose somebody is having a lung cancer and having sudden onset of the back pain, or somebody in the 60s having the first time sudden onset back pain, you have to rule out the multiple myeloma. So when you are suspecting the tumor, that also comes under the red flag. If you are having the the infection you're suspecting by the total count or by the negative cardiac signs, that is also a red flag. If you are having the neurodeficits can be divided into three major categories: autonomic, motor, sensory. So most dangerous is your autonomic. And which type of autonomic fibers? We'll be discussing about the next module, sympathetic. That time we'll be talking about the sympathetic system in detail. But for today, just remember that within the spinal canal, we are having the two types of autonomic fibers, sympathetic and parasympathetic. So sympathetic is known as the thoracolumbar and parasympathetic is craniosacral. That means parasympathetic comes down along the spinal cord and comes out to the sacral foramen, S2, S3. Whereas the sympathetic, it's thoracolumbar. From thoracic 1 till the lumbar 2, the sympathetic fibers comes out. After lumbar 2, there is no sympathetic fibers within the spinal canal. This information is very, very important. After L2, all the sympathetic fibers are outside the spinal canal. So you know that there is a sympathetic chain on either side of the body, anterolateral side of the body, which is starting from the coccyx C1, means cervical 1, till the coccyx 1. We are having the two sympathetic chain at the front of in front of the coccyx 1. We are having the two sympathetic chain is joining together and forming the last sympathetic ganglion, call as a ganglion impulse, right? So the sympathetic chain is outside all throughout, but inside are there from T1 to L2. After L2, there is no sympathetic fibers within the spinal canal. That means in the lumbosacral pathology, lumbar 5 and sacral pipe, this area's pathology, which fibers will be involved? Sympathetic or parasympathetic? Answer is parasympathetic. Because parasympathetic fibers are within the spinal canal, they are coming out through the S2, S3 foramen. Whereas last sympathetic fibers comes out along with the L2 nerve root. After that, sympathetic fibers are all outside the spinal canal, not inside. So that means in any spine pathology, like say, for example, is a very big prolapse disc, or there is an hematoma, or there is a tumor, or whatever it is within the spinal canal, which fibers will be affected? It's the parasympathetic. Sympathetic fibers will be escaped. Okay, so this I was trying to, in the last class also, I was trying to explain that, what happens, whether the urgency or frequency of the micturition or retention of the urine, which one is red flag? So we discussed that retention of the urine is the red flag. It's not the incontinence of the urine, which is patient is unable to hold the urine, is not a red flag. So why? So now coming to this question, why? So bladder and bowel is controlled by sympathetic and parasympathetic. So what is the function of the parasympathetic? Parasympathetic nerve is known as the nerve of voiding urine or voiding stool. So what is their role? They are relaxing the sphincter and they are contracting the smooth muscles so that stool or urine is evacuated, right? So parasympathetic fibers helps us to void urine or stool. Relaxation of the sphincter and contraction of the smooth muscle, that like for the bladder detrusor muscles. And what is the function of the sympathetic fibers? Opposite. Means it causes constipation, it causes the retention. So that means there will be constriction of the sphincter of the bladder and relaxation of the detrusor muscles for the bladder. For the stool, for the bowel, it's a little complicated. You know why? Because in the bowel, in the anus, there are two sphincters. External anal sphincter and internal anal sphincter. External anal sphincter is controlled by the voluntary muscle. You can voluntarily contract or relax the external anal sphincter, right? So that is a skeletal muscle that is controlled by the somatic motor fibers, right? Whereas internal anal sphincter is smooth muscle. It's not a skeletal muscle. And that is being controlled by the autonomic fibers, sympathetic, parasympathetic. So parasympathetic relaxes and sympathetic closes the sphincter, right? So now, what happens if suppose there is a huge prolapse disc and it is the compressing the cauda equina fibers? So what will happen? Somatic nerves will be injured and autonomic fibers also will be injured. Which autonomic fibers? It is parasympathetic, not the sympathetic, because sympathetic fibers, after L2, there is no sympathetic fibers within the spinal canal. So if there is L1, L2 disc or above, then it might be. But L2, L3 or below disc, the sympathetic fibers within the spinal canal are not there. So they are not being injured because they are outside the spinal canal. So if parasympathetic fibers are damaged there, first of all, if the other caudal fibers will be damaged, what will happen? Because these all are lower motor fibers. Why? Because upper motor ends at the level of the L1, right? After L1, there is no spinal cord. That means after L1, there is no upper motor is coming down. All the upper motor fibers are ending at the level of the L1 or above. So after L1, all are lower motor. That means caudal fibers are lower motor fibers. So if there is a compression, if there is a huge compressing the caudal fibers, what will happen? There will be flaccid paralysis. You remember, no? The upper motor neural lesion signs and lower motor neural lesion signs. Upper motor neural signs means there is spastic paralysis. The jerk will be exaggerated. There will be clonus, the diabetic sign. All are the upper motor neural lesion signs. What are the lower motor neural lesion signs? There is flaccid paralysis. There will be loss of muscle tone. There will be loss of reflexes. Babinski sign will be non-responsive. So these are all the lower motor neural lesion signs. So caudal syndrome or the Hughes prolapse, hematoma, the fracture, the tumor, all this compressing the caudal fiber is a very important red flag. So what happens here? There will be flaccid paralysis, right? Because lower motor neural lesion. Then what happens to the bladder? Parasympathetic fibers are damaged. Sympathetic fibers are escaped. So what will happen to the sphincter? Sphincter will be constricted. Because parasympathetic fibers relaxes it. They are damaged, so they cannot relax. So sympathetic fibers is overactive. So the sphincters are constricted. What happens to the detrusor muscle to pass the urine? Detrusor muscles are relaxed because parasympathetic contracts the detrusor muscle. So they are damaged. So detrusor muscle is relaxed. Sphincter is closed. So what will happen? Patient will be unable to pass urine. And this is extremely dangerous. These patients need immediate surgery. Okay, immediately refer this patient to your surgical friends for the surgical interventions. 48 hours, within 48 hours, the surgical decompression should be there. If you're delaying it further, the patient will be, for the whole life, will be under the catheter. He'll need a catheter to pass the urine. Remember, it's so dangerous. And you have only 48 hours time to do the surgical decompression. So if you're getting this kind of patient who is having the back pain, unable to walk, unable to sit, and unable to pass urine, consider it a very, very medical emergency. You have to, these patients need to evaluate it immediately with an MRI, and surgical intervention is an emergency. Right? So this is about the bladder. For the bowel, the situation is a little complex. Why? Because I told you there are two sphincters. One is controlled by the autonomic fibers, that is internal anal sphincter. Another is your external anal sphincter, which is being controlled by the voluntary muscles. So here, there is some irony. You know what is that? That means here, patient will not be able to pass stool. Right? Because internal anal sphincter is tight, constricted. But if you're doing a parectal examination, what will happen? You'll see that the sphincter tone is gone, no sphincter tone, and perianal anesthesia. So remember, this is caudal syndrome. So in the caudal syndrome, parectal examinations is mandatory. You have to do a parectal examinations. You have to look for the perianal anesthesia. You have to look for the external anal sphincter tone. So the external anal sphincter will be relaxed. Why? Because of the lower motor neural lesion. Because these are skeletal muscles. These are supplied by the, mostly the LS5 and COX6-1 fibers. So, and they are lost, damaged, lower motor neural lesion. So external anal sphincter will be laxed. Whereas if you are introducing your finger further, you'll see that the internal anal sphincter is constant. And if the surgery is not done, what will happen? manual evacuation of the stool. Patient will not be able to pass stool. So we have seen this kind of patient where surgery was not done in time and the patient is on catheter. Patient is, evacuating the stool with the manual evacuations, passing the fingers through the internal anal sphincter, and then only they can pass the stool. So this is extremely, dangerous conditions. So these patients is out of all those neurodeficits, autonomic motor fiber damage is extremely emergency. These fibers are very sensitive. Unless the surgical decompression is done within 48 hours, there will be permanent damage of the parasympathetic fibers, right? So, neurodeficits, the most important is your autonomic fibers. And which autonomic fibers? It's the parasympathetic fibers. Then comes motor. Next important. Motor again, if you're quickly recapitulating the grades of the motor fibers, remember, 0 means nothing. 1 means just a flicker without movement of the limb. 2 means if the gravity is eliminated, that means on the bed, patient will be able to move it. Grade 3 is against the gravity, but not against the resistance. Grade 4 is against weak or mild resistance. Grade 5 means normal. So you remember this muscle power grades. So mild motor weakness is not a red flag. Mild motor weakness can be also because of the pain. So the up to which it's red flag, up to 3 is red flag. So 4/5 is not a red flag. 5/5 is a normal. 4/5 is not a red flag. 3/5, 2/5, 1/5, or 0/5, those are the red flags. And here also surgical decompression is needed if the red flag is there. That means if somebody's motor power is 3/5, the patient should be surgically decompressed. And here time is little longer. The best results are if the surgical decompression are done within 4 weeks, right? After 4 weeks, chances of the motor recovery is erratic. You cannot predict how much recovery will be there. After 3 months, the recovery chance is very minimal, right? So the autonomic and the motor, both are dangerous, but autonomic is more dangerous because there the surgical decompression should be done within 48 hours. For the motor, suppose the somebody don't have the autonomic fibers dysfunction, having only the motor function dysfunction, there you are getting some more time. Then up to within 4 weeks, you have to do that. Sensory, it's not a red flag if the sensory deficit is a fixed, not increasing. Like suppose somebody is having a little bit of numbness in the medial aspect of the lateral side of the foot, and it's fixed. So it's not a red flag. But if it is progressing, means this area, gradually this area, or this area, or the quality of the numbness, initially maybe the 10% numb compared to the normal side, then it becomes 20%, then it becomes 30%. So the quality of the numbness is increasing, or the area of the numbness is increasing, then it is red flag. So if it is a fixed numbness, it's not a red flag. But progressive numbness, it's red flag. So neurodeficits you have to understand very nicely because here the surgical decompression is needed. Now, severe pain. Is it a red flag? So remember the first day's class. Pain and tissue damage don't have any linear relationship. That means severe pain doesn't indicate that the tissue damage is very severe. That means tissue damage, severe pain, they don't need any interventions at the beginning. But suppose somebody is having a, you are doing conservative management and still the pain is there, or even you have given some epidural steroid injection and still the pain is there, or some temporary relief, then it becomes a red flag. That means failure of the conservative management or failure of the interventional management is a red flag for severe pain. Otherwise, severe pain is not a red flag because we discussed in the first class that the pain intensity and the nature of the tissue damage don't have any linear relationship. So there are a lot of other factors in there which actually contributes to the pain. So remember these red flags. If the red flag is there, then you have to immediately have a multidisciplinary team to manage this patient. And one surgeon is mandatory in this team because many of these patients, timely surgery is very, 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 very important. Okay, so when our fellows discuss us, ask this question to me, sir, when can I start my pain practice? What is my answer all the time? I always tell one thing, that starting pain practice, your anesthesia degree or other postgraduate degree is enough to start the pain practice. But what is very important, that you must be having a thorough knowledge of all the different types of red flag. Means, what are the red flags for the headache? What are the red flags for the neck pain? What are the red flags for the hand pain? Like all. Why? Because just now I told, suppose you are a pain physician, so you don't have any idea about the red flags. And you are seeing a patient the patient is unable to pass urine. And you are putting some catheter to pass the urine and not doing any other further investigations and having the diagnosis, whether it can be a Kordaikonis syndrome. And 48 hours passed, golden time passed, patient will be permanently on catheter. So similar kind of things are there in any other red flag. So red flag identification is one of the very, very important step in your clinical evaluation. You can't miss a red flag. That means the minimum qualification to start pain medicine practice is ability to identify the red flags. That you must be having. If you are ruling out the red flag, then you can have the time to go ahead further. Okay, so causes, red flag, then comes your history. In general history, what is important is chief complaint, and then the history of presentation. I'm not going into the detail. One of the YouTube video is shared in your dashboard. You please go through that video, that art of history taking. So there, the different types of aspect of the pain, and the quality of the pain, how to assess the neuropathic pain, what are the other questions to be asked, like aggravating factor, relieving factor, onset, chronicity. So all those things should be asked, questions should be asked. I'm not going into the detail of that. That is there in your YouTube channel, because YouTube links in your dashboard. So these are all different kinds of history. Then comes examination. I'll be starting from here. The inspection, palpation, range of movement, neurological examinations, and special clinical test. And when I discuss this slide, I always proudly say that before our book on the clinical methods in the pain medicine, in the whole world, there was no systemic ways how to examine a patient of pain. Means pain medicine specialty was badly needed a systemic ways of doing the examination of the pain. So our clinical method book was the first book in the whole world where we have systematically arranged what are the steps of doing a clinical evaluation suffering from the pain. So basically, it's a combination of the musculoskeletal system examination and the neurological examinations for the pain medicine specialist. So inspection, like, suppose somebody is is a cardiologist or somebody is a pulmonologist. So what are their steps? Inspection, palpation, percussion, auscultation, right? So, but for the musculoskeletal and the neurology, it's a little different. So for the pain, it's a combination of the musculoskeletal system and the neurology system. So here, inspection, palpation, range of movement, both active range of movement, passive range of movement, then whole neurological examinations, and then special clinical test. Now, inspection. Inspection, what's the posture? What's the gait? How the patient is sitting? Suppose the patient is tilted. Sometimes you'll be saying that the patient is sitting tilted on one side. What are the possibilities? That means this side muscle might be in spasm, or this side facet joint might be very painful, so that the facet joint is unload. To unload the facet joint, you are tilted like that. So how the patient is sitting, or sometimes flexion causes pain. So patient is sitting like this, or sometimes extension causes pain. The patient is sitting like this. So how the patient is sitting, what is the posture? Can give you some important clues. What's the gait? How the patient is walking? Whether there is an antalgic gait, whether there is different tendon and back gaits. There are different kinds of gaits are there. So you have to understand, you can have some clues depending on the gait. Then you should be looking about the muscles. Lower motor neuron lesion can cause the atrophy of the muscles. So whether there is any muscles, what is the shape, what is the contour, because the measuring the limb girth is very important to understand how much muscle atrophy is there. And if muscle atrophy is also a red flag, because that might be indicating the lower motor neuron lesions. Then the color, swelling, any scar marks of previous surgery. So all those things should be noted in the inspection. Then palpation. Palpation, I always tell that it is a very wonderful, the clinical examination steps, which will be whether you are getting the tenderness or whether you are not getting the tenderness, both are important, right? Suppose you are examining a patient of the back pain and you are getting tenderness. Then you say, okay, yes, it's painful. Then what you should be thinking? That your superficial structure is the source of the pain. Like it can be facet joint, it can be muscle, it can be interspinous ligaments, it can be sacroiliac joint, right? You cannot palpate a disc. You cannot palpate a vertebral body. You cannot palpate psoas muscle, which is because they are deep. You can palpate the erectospinal group of muscles. QL muscle is also difficult to palpate. But still you can palpate. But psoas you can't. So that means when you are eliciting the tenderness, that means your pain generators are superficial, right? And if you are unable to elicit tenderness, many times it will happen. Patient will be telling, here is my pain. And when you are trying to palpate, nothing is there. There is no tenderness. What does it indicate? So this is also value that pain is there, but tenderness is not there. That means the deeper structures are the source of pain, right? So tenderness or not having the tenderness, both are having value. In fact, what is very important to understand that there is pain, but there is no tenderness. It's more dangerous than if you elicit the tenderness. Why? Because they are all deeper structures within the spinal canal, in the vertebral body. So they are more dangerous. They are close to the neural structures. If it is a superficial tenderness, like facet joint, like erectospinal muscles, it is less dangerous. So elicitation of the tenderness is one of the very important clue to tell you what is the pain generated. Is it superficial structures? If it is superficial structure, which superficial structure? Is it facet? Is it SI? Is it erectospinal muscle? Is it interspinous ligament? So all the superficial structures you can palpate and you can have some idea about how from the pain is coming. And if you are unable to elicit the tenderness, means you have to think it can be psoas, it can be disc, it can be some neural canal structures where you are unable to elicit the tenderness, right? So it should be palpating the joints, bursa, ligaments, muscles, tendons, and try to find out how is the pain generator, whether you are able to elicit the tenderness or not. Then come your range of movement. So there are lots of joints in the back. So hip and spine, both. So flexion, extension, rotation, lateral bending. These are all for the spine. But always remember that the hip joint should be always included in a patient having the buttock pain, back pain going down to the leg. I've seen so many patients in my practicing life where a simple neck femur fracture or avascular necrosis of the hip has been missed by very renowned, the surgeons, orthosurgeons, neurosurgeons. They have missed it because they have not examined the hip properly. So they have just gone through the MRI. MRI was having some disc bulge, and they are pointing, okay, here is my pain generator, here is my pathology. And remember, last day we discussed that asymptomatic disc bulge is there very common in more than 80% if the patient is elderly. So this asymptomatic disc bulge should be ignored if we are getting some other findings which is matching clinically as well as the investigation wise. So never ever rely absolutely on your image findings. You have to correlate with your clinical findings. That is the reason why you must be always examining hip when you are examining the patient who is having the back pain radiating down to the leg. So, and both active and passive. Then neurological examinations, I'm not going to the detail of that. The higher functions, cranial nerve examinations, the upper motor, upper limb, lower limb. No, I'm again telling this story that at least several patients I have seen like this, that this patient was having the back pain, difficulty in walking, and proper neurological examination was not done. MRI was showing a big prolapse and it was operated. And there was no improvement of the symptoms. Ultimately, it was seen that the patient was having the cervical prolapse for which patient was unable to walk. And there, the disc bulge was just a coincidence in the lumbar area. So if the proper clinical evaluation is done, then it was found that there is a upper motor neural lesion of the lower limb. That means knee jerk is exaggerated, ankle jerk is exaggerated, Babinski sign is positive, which is telling that the neurological lesion is not in the lower lumbar area. If the lumbar area neurological lesion will be there, what will be happening? There will be lower motor neural lesion, because as I told you earlier, that spinal cord is ending at the level of the L1. So that means the back pain pathologies should not have the upper motor neural lesion. If the patient is having the upper motor neural lesion, definitely the pathology is up, not in the lumbosacral areas. So lumbosacral area pathology, that means lower, what is the area? Okay, I forgot to mention these things. That means which part is known as the lower back. Lower back means it is the lumbosacral areas. Below the 2 and 3, it is a lower back areas, and it includes the buttock areas as well. So the lumbosacral areas is lower back. So that means anybody having a lumbosacral pathologies should not have a upper motor neural lesion. So if you're doing a thorough clinical neurological examinations, we could easily find that this patient was having the upper motor neural lesion. So the pathology must be in the cervical areas or thoracic areas and not in the lumbar areas. So surgery in the lumbar disc is not going to correct. We are basically missing some other pathologies. So several patients we have seen like that in my, the journey as a pain physician. So what is important here to remember that do a thorough neurological examination of the both upper limb and the lower limb and try to understand if there is a neuro deficit, and if it is there, then whether it is upper motor neuron or lower motor neuron. Okay, so then comes your special clinical test. Special clinical test, the test, we have categories, there are 4 kinds of special clinical test. One is test for the lumbar nerve root irritations, test for the spinal canal stenosis, test for the sacroiliac joint pain, test for the piriformis myofascial pain. There are some other tests there, but these are the common things. Then first comes the lumbar nerve root irritations. So this is the straight leg rising test. This is the most commonly performed test. But what is important here to remember that the straight leg rising test can be done by the lying down like this, and opposite leg should be flexed. That is very important, opposite knee. And if the patient is having back pain, is it positive? Answer is no. Patient must be having the radiating leg pain. Then only will be considering as an SLR positive. And it must be between 30 degree to 65 degree. Then only it will be considering as a nerve root irritation as a cause of the pain. Right? If it is below 30 degree, means it is non-specific. It can be because of some other reasons as well. If it is more than 65 degree, then also it might be because of the something else. If there is a back pain, that is not SLR positive. But another thing to remember that it can be done also in the sitting posture. That stretching or extension of the knee is most important factor. Extension of the knee and flexion of the hip. But these are for the lower lumbar, means L4, L5, S1. Let's suppose somebody is having the L1, L2, L3 or upper lumbar root irritations. Then is it the SLR positive? It will be positive. Answer is there is another test which is not shown here. Is a reversed SLR. Means patient will be lying prone and you raise the leg. That means you are doing extension of the hip. So extension of the hip is needed for the upper lumbar. This is known as reversed SLR. Patient is lying prone and you are raising the leg. You are doing the extension of the hip. And if that causes the radiating pain, that means it is reverse SLR positive, which indicates that it might be the upper lumbar radicular pain. But upper lumbar radicular pain is rare compared to that of the lower lumbar or the sacral radicular pain. Okay, so this is for the nerve root irritation. Then comes the test for the spinal canal stenosis. Remember the pathology, so what happens in the spinal canal? Spinal canal stenosis means it is a narrowing of the spinal. So the blood supply to the nerve is being compromised. And the patient's primary feature will be what? Is your neurogenic claudication. Patient will be having the pain, numbness, weakness, heaviness when the patient is walking. If the patient is stooping forward, bending forward, what will happen? It will be relieved. Why? Last day I tried to explain it. That when you're flexing the spine, then the lamina is getting separated. So the ligament and flema between the lamina is traced. So the spinal canal diameter will be increased. That means by flexing forward, we can increase the spinal canal diameter. And based on that, we are having a lot of tests. One is stoop test. Stoop test is what? Patient is stooping forward to have the relief in the pain. And you'll see a lot of elderly people, because spinal cord stenosis is the disease of the elderly. So patient will be walking. After some time, his leg is heavy, weak, pain, cannot stand, cannot sit anywhere because there is no sitting option. So what will he do? He'll be leaning forward like this. Leaning forward means flexion of the lumbar spine, which will be increasing the canal diameter. This is stoop test. There is another sign which is not mentioned here, which is known as shopping cart sign. When you are holding the shopping cart in a mall, what happens? We are holding and we are flexing forward, and that will be relieving the patient's pain. So stoop test and shopping cart sign are basically similar. Means flexing forward relieves the pain, back pain as well as the leg pain. And chem test is what? It is opposite. You ask the patient to extend and keep it for some time, and the patient's leg pain will be reproduced. If there is unilateral symptom, then along with the extension, it will do the lateral bending as well. So that will further compromising the neural foramen. And this is known as chem test. So extension and lateral bending is going to reproduce the patient's leg symptoms, and that is known as the chem test. So stoop test, shopping cart sign, and chem test, this is the test for the spinal canal stenosis. Then for sacroiliac joint pain. Sacroiliac joint pain, you see, there are so many tests. Another test is, I have not mentioned here, is a 14-finger test. 14-finger test means you are asking the patient, where is your pain? For the sacroiliac joint pain, patient will be exactly pinpointing the area that over the sacroiliac joint, that here is my pain. That is known as 14-finger test. And apart from that, there is 6 other tests. So what is important, that if 3 clinical tests is positive for the sacroiliac joint, then most likely the sacroiliac joint is the source of pain. Otherwise, when you are suspecting the sacroiliac joint pain or when you are suspecting the facet joint pain, the best test to confirm or to rule out is to give the local anesthetic in the joint or into the nerve supplying the joint. So this is for SI joint and facet joint. But clinically, if out of all these, the 3 is positive, then it is most likely that sacroiliac joint. What are these tests? One is distraction test. What is distraction test? Patient is lying supine and you are pressing over both the anterior iliac spine. You are distracting both the iliac bone, and then there will be pain will be reproduced on the affected side. If it is bilateral on both the side, there is thigh thrust test. So in this way, we are putting pressure over the thigh, and that is putting the loading of this side sacroiliac joint. So thigh thrust test to be done on the affected side, or you can do in both the side in this way on this left side as well as the right side. Then this is thigh thrust. Then is sacral thrust. Sacral thrust is what? You put your palm over the sacrum and press it, and you see if there is a pain either side or one side, which side is painful depending on that. Then is Gensley's test. So one is the leg will be hanging like this on the table, side of the edge of the table. Another you are flexing, and you see which side is having pain. Then is on the lateral decubitus, compress the iliac bone, and you see whether that is producing pain. So this is compression test. There is Faber test. Faber means flexion, AB means abduction, ER means external rotation. So flexion of what? Flexion of the hip, and then you are doing the abduction and external rotation, putting pressure over this knee joint, and that is known as the Faber test or Patrick's test. So this is again very important. But remember, the Faber's test or Patrick test is not specific for the sacroiliac joint pain. If the pain is completely anteriorly here, then it can be because of the hip as well. And if it is over the sacroiliac joint, then it is because of the sacroiliac joint. So Faber's and Patrick's test is not specific for the sacroiliac joint. Remember that. So out of all those tests, if 3 tests is positive, include the 14 test also. That means out of 7 tests, if 3 is positive, then you can tell that this is your sacroiliac joint pain, most likely. But confirmation should be done by the local anesthetic injection in the joint. Then piriformis. Piriformis is one very important muscle there, which is an external rotator. What is the attachment of the piriformis? One side, it is originating from the lateral border of the sacrum, S to ST particularly, and inserted at the greater rotator. It is an external rotator of the leg. So that means when the piriformis is contracted, the leg will be abducted and external rotated. And if you are doing the opposite thing, That is your fair test. Fair test can be done on the lateral decubitus or it can be done on the supine position. So what you are doing? You are doing the internal rotation and abduction by adduction by pushing the knee joint, and you are doing a flexion of the hip joint. So what is fair test full form? Flexion, adduction, and internal rotation. Fair test. So pushing the knee is causing the adduction and the internal rotation of the hip and your flexion of the hip. This is your fair test in the lateral decubitus. So this is one of the very common test. Then this is your only internal external rotation. You do the internal external rotation. Internal rotation will be relieving the pain. Oh, sorry, increasing the pain, and external rotation will be the relieving the pain. So this is known as the Freiberg's test. And in British test, it is almost similar. Here you are again putting this leg, this leg will be straight, and you are putting this leg pressed over this knee. It is almost a fair test in the lateral position. So only thing is here you are just not putting over this straight leg. It can be hanging. You can put one leg hand here, another hand here to do the internal rotation and the adduction. Here you are putting it and just pressing over the knee, and that is again causing the internal rotation and the adduction, and that will be painful, and that is your British test. So British test, Freiberg test, and the fair test these are for the piriformis. Again, piriformis syndrome can be confirmed with the diagnostic local anesthetic injection into the piriformis, and that confirms the diagnosis. Okay. So this much, and now time for quiz. So quickly, two, three quizzes are there. So which test is for piriformis syndrome? Pair test, stoop test, sacral thrust test, chem test. Okay, very good. All has answered right. Very good. Okay, next question. Which test is for spinal canal stenosis? Sacral thrust, chem test, pair test, SLR test. Again, I want 100% correct answer. But again, for test, spinal canal stenosis is your chem test. SLR is for prolapse disc, radicular pain. Remember these things. That day, last day, I discussed about the three different disc pathologies. One is internal disc disruption, which will be present with the diffuse back pain. Second is the disc prolapse, which will be producing the radicular leg pain. So the SLR test is for the radicular leg pain. And spinal canal stenosis. Spinal canal stenosis means patient will be presented with the neurogenic claudication. Patient is comfortable on sitting, but on walking, patient will be having the neurogenic claudication, pain in the leg, as well as the numbness, weakness. All these things will be there. So the SLR is for the prolapse disc, and chem test, stoop test, shopping cart sign, these are for the spinal canal stenosis. Okay. So which test is for the lumbar nerve root irritation? SLR, chem, fair, sacral thrust. Again, I want 100% right answer. Okay, very good. So 100%, all of you answered right. And the last question now. Which test is for the sacroiliac joint pain? Distraction test, SLR test, chem test, stoop test. Oh, for wrong answer again. Distraction test. Remember what was the distraction test? Patient is lying supine. You are putting over the two hands over the two anterocephalus spine, and you're putting it, distracting it, and loading the sacroiliac joint. So painful side will be having the pain. Okay, so let us see who scored highest. So Niveda is third. Dr. Charu is second, and let's see who is first. So Dr. Suraj. How is Dr. Suraj?
Namaste, sir.
Yes, very good. Okay, so this much from my side. If any question, I'm sure series has taken care of all the question, but still, if you wish to ask any question live, you can. Any more questions for me?
Hello, sir.
Yes.
How are you today?
Yes, I am fine.
If there is a lesion in L1,
Yes.
what will happen regarding the urine retention, parasympathetic and sympathetic?
Sympathetic might be. So depending upon the which fibers are more damaged, depending on that, the symptoms will be there. Okay.
So it could be urine retention or urine incontinence.
Right. But the chances of the urinary retention is much more. Because parasympathetic fibers are more, what should I say? More, the vulnerable structures. Okay. But again, it may be the sympathetic as well. But in general, common rule is because L5, L1, L2 level pathology is rare. So the most common level of the pathologies are always the lower back, the lower lumbar or sacral. So that is the reason why it's almost synonymous that anybody having any red flags in the lower lumbar or the sacral areas, there will be a retention of the urine.
Thank you, sir. Thank you.
Okay. Any more questions? Good question. Any more questions from anybody? No? Okay, then give me some time. We'll be preparing the cameras and lights and all those things, and then we'll be okay. So give me some time. We'll be ready. You can have a quick break, or you can continue discussions with Dr. Series. You can ask this question directly to Dr. Series by unmuting yourself. Okay? Series, please continue the discussions with any question that is there. You can talk. Meanwhile, let me prepare the cameras and all those things. Okay?
Yes, sir.
Okay.
Hello, Suraj. Congratulations.
Thank you, sir. Kire, I want to ask you a question. What is the difference between cauda equina and conus medullaris syndrome, and how will you recognize those based on clinical sign and symptom?
The conus medullaris is the last part of the spinal cord.
Yes, sir.
Okay. So there is mainly sacral and coccygeal spinal segment comprises of conus medullaris. So if there is any lesion in conus medullaris, most of the symptoms will be upper motor neuron lesion type of, because the insult is at the level of spinal cord, right? Hello, Suraj?
Yes, sir.
Okay, but in cauda equina syndrome, normally the pathology is below the level of L1. So most of the clinical features will be of lower motor neuron type, because the fibers are already out of the spinal cord.
Yes. So both will present as
One will be
bowel
the
and
features
bladder
will be,
dysfunction.
yes, but one will be of sympathetic nature, another will be of parasympathetic nature. Yes, but not only that, you also have to go for the neurological examination by, like, there will be rigidity in case of conus medullaris. There will be spastic type of paralysis. Clonus will be there, but in the cauda equina, these features will be not there, and lower motor neuron lesion features can also be there, like flaccid paralysis, like sir has just explained regarding the anal canal tone. So apart from the other neurological features, in conus medullaris syndrome, most of the clinical features will be dominated by the upper motor neuron type. But in case of cauda equina, most of the clinical features will be dominated by lower motor neuron type. Okay.
Okay, thank you, sir.
Okay. And we frequently encounter this cauda equina syndrome in OPD. So as sir has mentioned, you should be able to identify. Normally, what we do is we just ask the patient if there is any problem with bowel and bladder. So that has to be asked to all the patient who is coming in OPD for low back pain, especially the radiating pain, because we should not miss the bladder and bowel dysfunction.
Sir, good evening, sir.
Good
Good evening, sir.
Lavanya. Good evening.
Sir, actually, when I was working in the periphery 10 years back, we used to encounter like for every C-section, they used to just use heavy locks, sir, for the spinal. And consequently, we used to encounter a lot of patients with cauda tendinitis and severe low backache. Especially, they used to say it used to be very severe while sitting. It is somewhere in the coccyx and all. They used to say the cauda tendinitis. How should that be managed, sir?
So what is the presentation? What is the duration of the back pain and the cesarean? Normally,
Sir,
is it an
actually, it used to be almost
chronic?
almost ranging from 3 months to 1 year, 2 years following C-section. They used to come, sir, and all the patients were from the
So this is
same area
common
of
in
hospital.
my place also. Normally, a lady who has undergone cesarean, especially post-spinal, they
Yes, sir.
usually come to clinic blaming that they blame everything to that spinal anesthesia. But most of the time, the cause is not the spinal anesthesia. There may be other causes like discs or interspinous ligament sprain. But in my place also, this is a very common misbelief that if any young lady or middle-aged lady has a back pain, and most of the lady has already has already received spinal anesthesia, so they link all the back pain to that spinal anesthesia, which is usually not true. That is common in my place also. It is basically they blame everything for that spinal anesthesia. Okay, it might be just a mere coincidence, but other causes can be there, especially the age profile that comes to the clinic is usually housewife, and they have to do lots of household job like washing clothes, like sitting or brooming, and they all require bending forward job, no? So because of
Yes,
this,
sir.
the housewives normally usually have back pain, but they relate that back pain everything to the spinal anesthesia.
Pardon me, sir. No, sir. Like from my history, that specific hospital which was using heavy locks, they used to complain severe pain in the coccyx, tenderness,
Evilox, Mani, what
everything.
is
Only
Evilox?
it is 5% lidocaine, sir. 5% lidocaine.
5% lidocaine?
It was used for
I
spine.
have no
They
idea.
used to use
Maybe
5%. The low back pain, what every women in the postpartum complaints, including me, is in the L3, L4, L5 areas, sir. That is a different
maybe
context, sir.
maybe that is related to lignocaine, like heavy lignocaine that they are using. I have no
Yes,
idea.
sir,
But
sir.
normally what um
This was typical to that area hospital where they were
maybe the
very
problem with
frequently using
is
this
the
one, sir.
batch of the drug which is being.
No, sir. It
It
is
must be
nothing
related to
related to the
lignocaine.
batch, sir.
Otherwise, I've been
They
using.
lidocaine. Yes, sir.
Yes,
It's nothing.
chemically they might be irritating the cauda equina fibers, and there might be some chemical irritation. I have no idea regarding that. I'm sorry to tell.
Okay, sir. Thank you, sir.
Yeah, hello, sir. Good evening.
Hello, sir.
Okay, thank you.
Hello, sir. Good evening.
Good evening, Pius.
Sir,
Good
just
evening,
want
Dr.
to.
Pius.
Yes, sir. Sir, I want to ask one thing. That one patient today came with MRI, lumbosacral spine,
Mhm.
and the report was saying mild disc prolapse. So
Okay.
I want to know when intervention should be needed for mild, moderate, severe. Or in cases mild, we have to go for first physiotherapy. Kindly advise.
No, yes. You have to understand that most of the disc prolapse, about 80% of the disc prolapse will resolve by itself. The body will take care by itself. So if there is no red flag, as sir has just mentioned, then and you can easily wait for about 4 to 6 weeks, because it is a cell. Most of the cases, 60 to 80% case, it resolves by itself by 8 weeks or maximum by 12 weeks. So if there is no, if the patient doesn't recover within 8 weeks, 4 to 8 weeks, then only you should think of going for intervention. But
Okay,
more
Siri,
time you can. Yes,
I'm
sir.
here.
Yes, sir.
Yes.
Please continue.
What is more important, that this is the rule. Remember this rule, that the mild prolapse disc normally do not produce any symptom, rarely causes symptom. So that means if somebody is having a back pain and MRI is showing your mild prolapse disc, what I'm trying to emphasize yesterday's class, today's class, that never ever tell these things 10 times. Never ever, never ever, never ever read the MRI report. You first do your clinical evaluation, and then you see that whether it is matching with your MRI or not. Almost 99.999999999% mild prolapse discs do not produce any symptom. So this question is not a good question, that what should I do for a mild prolapse disc? What should you do for a mild prolapse disc? You forget about MRI. Why have you seen the MRI report first? That should not be seen. You first do your clinical evaluation. Whether your patient's back pain is because of the facet joint, because of the SI joint, because of the IDD, because of the myofascial pain, and then look for the MRI report. MRI report is not a clinical diagnosis. Do not consider mild prolapse disc as a cause of the pain in most. It doesn't carry any meaning. And what is important here is your clinical evaluation. If it is a matching with the MRI findings, then only give the importance. So mild prolapse disc sometimes causes the discogenic back pain. Mild prolapse disc do not cause any radicular pain, or the prolapse disc. Radicular pain is extremely unlikely because of the mild prolapse disc. Mild prolapse disc extremely unlikely to cause the spinal stenosis. Mild prolapse disc in the younger patient sometimes causes the discogenic back pain, but mild prolapse disc is almost normal in almost always. Understood? So what is bottom line is, you do not read your MRI report. You do your clinical examinations. You remember what are all the causes of the back pain, and then you look at your MRI. If your clinical diagnosis is discogenic back pain and there is a mild prolapse disc, then this considered this is having value. Otherwise, it don't have any value. Okay?
Thank you.
Okay, so we are ready for the procedures. If still you are having some question, Siris is there to answer your question. Dr. Hori is there to answer your question. You can put your question there in the chat, and let us continue with this today's procedure. So today we are going to cover the 3 important procedures, very common procedure. One is your sacral joint injection. One is your caudal epidural. And remember, most of you are anesthesiologists. You might be thinking caudal epidural not a big deal. We are doing it blindly, or we are doing it under ultrasound. But remember, the caudal epidural steroid injection, injecting the particular steroid, should always mandatorily done under the fluoroscope. That is mandatory. Why? Because let me tell this story, because I always share this story whenever I demonstrate the caudal epidural. So this was in Kolkata only. Fortunately, not in our hospital, but it happened in Kolkata only. So they was given caudal epidural under the CM guidance, but they ignored the vascular uptake. And they went on giving this caudal epidural steroid, particular steroid. Immediately, patient became unconscious, and they ventilated it because it was done in the OT. Patient recovered, and when the patient was gaining the consciousness, the patient was found quadriplegic. Quadriplegic, unable to move his hand, leg, sit. The patient was again ventilated, and with the conscious patient, but still patients need ventilation. After 1 month of treatment, patient was able to walk with a crutch. So what happened? What is the, why all those things happens? Because the blood vessels in the spinal canal are all continuous. From the sacral till the cervical area is continuous. And artery venous malformation is very common here in the spinal, asymptomatic. So what happened there? So it occluded the spinal vessels, the spinal artery, and caused the infarction of the cervical cord, and it caused the quadriplegia. So you can understand how dangerous it can be. And it is not the single case. If you're searching the literature, another information, some of you might be knowing, some of you might not be knowing, that in 2014, US FDA banned all epidural steroid injections, caudal, transforaminal, interlaminar, banned. They told that epidural injections cannot be steroid injection, should not be done because it is extremely dangerous. This was based on the decision that so many publications of the different complications because of the caudal epidural injections. So then the different pain societies appealed, and then the newer, the guideline came that all epidural injections, I always tell that epidural injection is the most dangerous in the spine because you are doing something in the spinal canal and a lot of blood vessels are there. So it must be done under the seal. And you have to inject the dye. You have to understand that it is not into the blood vessel, and then only you should give the steroid injection. Okay, so we'll be showing demonstrating the caudal epidural. We'll be demonstrating the sacral joint injection. Sacral joint injection, in contrast, is not that dangerous. And also the sacral nerve root, S1 nerve root. So there are the few things. So spice with me. So we'll be starting with the sacral nerve root injection. So the sacral nerve root injection, before she is doing the procedure, a little bit of background about the sacral nerve root injection. So again, if you are knowing this little bit of anatomy, then you'll be doing the less mistakes when you're doing this S1 nerve root block. So remember that all the nerve root, after coming from the foramen, what happens to it? It is divided into the ventral rami and dorsal rami. So ventral rami goes anteriorly through the psoas for the lumbar. For the sacral, what happens? It goes through the ventral foramina. So basically, there are two foraminas, ventral foramina and the dorsal foramina. So for the lumbar and the other nerve roots, they are dividing and going ventral rami going into the anteriorly, dorsal rami comes posteriorly over the transverse process. But for the sacral areas, there are two foramens, separate foramens. One is ventral foramen, another is dorsal foramen. So just look at here. See, so this is the ventral foramen. So the nerve roots which are coming is your ventral rami. So the nerve roots, ventral rami comes back to the ventral foramina, and these are the dorsal foramina. So the dorsal foramina, the dorsal rami comes. So now, this is special about the sacral nerve root. When sacral nerve root has the ventral foramina and dorsal foramina, and ventral foramina, ventral nerve rami, dorsal foramina, dorsal rami. So when you do the sacral nerve root block, what is our indication? What is our intention? Why we do the sacral nerve root or S1 nerve root block? Is it to block the dorsal rami? Answer is no. What is the supply of the dorsal rami in the sacral? Mostly they are supplying the multifidus muscle, and lateral branches supply the sacroiliac joint. So that is not the reason to block it. And no indication is there to just block the dorsal rami. We can block the lateral branches for the sacroiliac joint separately. That is a different issue. But when you're doing the sacral nerve root block, our target is ventral.
Please explain one more time. Explain one more time.
I should be repeating one more time. Hello?
Yes.
Yes, sir.
Yes.
So dorsal rami supplies multifidus, and the dorsal rami lateral branches. Dorsal rami has the medial branches, lateral branches. So it supplies the multifidus muscle, the medial branches, and the lateral branch supplies the sacroiliac joint. So for all the nerve root is dividing into ventral rami and dorsal rami. Now first, so the sacral, they are having the two separate foramen. Ventral rami goes to the ventral foramen, dorsal rami goes to the dorsal foramen. So dorsal rami supplies the medial multifidus muscles here and sacroiliac joint there. So when you do the sacral nerve root, our target is ventral rami, not the dorsal rami. Okay? Because radicular pain is because of the ventral rami. It goes to the ventral foramen, it forms the sacral plexus, and then it forms the sciatic nerves. It goes down and supplies the leg. So that is the reason why we go. What is the indication of the S1 nerve root block? If the patient is having the pain along the S1 nerve root, which part of the S1 nerve root? Ventral rami of the S1 root. That means, why I'm talking all those things? That means, if you are injecting here into the, just here, into the dorsal rami, dorsal foramen, you are wrong. Because the drug will not reach the ventral rami. So what do you have to do? My target is what? This ventral rami. So how shall I come to the ventral rami? Here. Shall I come to the pelvis? Perforating the bladder and the bowel? He says no. So I'll be coming here, but my route is here. So I'll be going through the ventral foramina, dorsal foramina, and through the dorsal foramina, then will come the sacral canal, and then I'll be entering into the ventral foramina, and ultimately my needle tip should be on the ventral foramina. Understood? So don't just put the needle here and that is not the end of the procedure. You have to enter through the dorsal foramina, enter into the ventral foramina, and then that will be the final approach. So let us see now how to do that. So first is true epi, like all the procedures, look at the true epi, and here in the
Sure.
and how to know as true epi?
So first, what we do is we take identify. We have in this position, we see that our X-ray beam is falling on the sacrum. Now, what we'll ask him to get a.
So this is the true epi image. Why true epi image? Because here you see the, okay, so let me start the annotation. So this is equidistance. Like last day we told that this is pedicle, this should be equidistant, then is a true epi. So first is true epi. And then what is, okay, let me explain this image as well. This is very, very important to understand that you see there are multiple foramens. Some foramens are here, some foramens are here, some small foramen, some large foramen. So remember, the small foramens are basically the dorsal foramen because the dorsal rami is small. So to accommodate the dorsal rami, these are the small foramens. But again, it is so confusing to understand which one is dorsal, which one is ventral. So, and another thing is what is important here to understand that your sacrum, see your sacrum is tilted not like this, it's tilted like this. So serum beam, if it is falling perpendicular, the ventral and the dorsal rami will not be coming in the same line. So you have to make a cranial tilt. If you're making a cranial tilt, then the ventral foramen and the dorsal foramen will be coming in the same line. So that we'll be entering into the dorsal foramina and entering into the ventral foramen.
So once we have taken an AP shot, we'll ask for a cranial tilt. So a slight cranial tilt.
And you see what is happening after the cranial tilt?
Okay, my pointer is near the left-sided S1 foramen. But here we are seeing the dorsal for S1 foramen as well as the ventral.
You see the serum is moved cranially. Picture?
So our target will be to overlap the dorsal foramen, dorsal S1 foramen, and we have to form a fish mouth. So if, as sir is pointing out, the fish mouth on the right side, what we are doing.
This part is overlapping. So this hypolucent areas, fish mouth appearance is where there is ventral and the dorsal foramina are overlapped. Understood? Everybody understood? So this white area where the ventral and dorsal foramina has overlapped, so that will be our needle entry point. We can make a little bit more cranial tilt as well. So they'll be overlapping, will be better.
Sure.
Okay, so you understand the whitemost part, that is our target. And we'll be going by the tunnel vision. term says you hit the margin of the and then you go, but it is not mandatory. You can go ahead directly and you check by the lateral.
We can
Okay,
take
short
that.
tunnel vision. And now we'll be going into the lateral. So you see what I was trying to tell, that our needle has not yet entered into the ventral dorsal foramina. So here is your dorsal foramina, and then this is the sacral canal, and then the ventral foramina will be from this area is your ventral foramina. So here is your dorsal foramina. We will be entering through that, and then so you see now we have entered through the because we have entered the dorsal foramina, and now we'll be advancing the needle further, so that it is entering dorsal foramina, ventral foramina cannot be assessed by the lateral view. Lateral view cannot assess. But you see, the needle is now passing, entering into the vertebral body. So here is the foramen. Okay, so this much. So now we have entered into the ventral foramen. So that is the end point. That means you should not be stopping the needle here or here or here, because if you are injecting the drug there, what will happen? The drug will be into the sacral canal, and very little drug will be entering into the, because the nerve root is coming like this, ventral rama is coming like this, dorsal rama is coming like this. So your target is this one. So for that, you need to introduce the needle further so that your drug is specifically deposited along the ventral foramina. Okay, is this clear to everybody? So this is the final needle position. Any question from anybody? Any question from anybody? Or shall I go for the next procedure? Okay, so next procedure we are going to demonstrate is the sacroiliac joint injection. So you see, before going into the sacroiliac joint injection, I'm just again showing you the sacroiliac joint. So you see, this is the sacroiliac joint. So just a minute. This is the sacroiliac joint. You see, this is the sacroiliac joint. Remember, the upper part of the sacroiliac joint is the fibrous part, upper and posterior, and the lower and the anterior part. See, this is the sacroiliac joint. So, anterior and the inferior part is your synovial part, and the upper and the posterior part is your fibrous part. So, this is the fibrous part. So now, through this fibrous part, you cannot enter inside the synovial part. Your target is synovial part. So when we will be having an AP image, see, these are the different layers you can see. One is your, see, just a minute, let me start the annotation so that you can understand it better. So see this one, this is one line. This is what? Iliac crest line. So see here, so this is the iliac crest line. You correspond with that. And then you see, this is another joint line. This is your posterior synovial joint. This line, what you can see here. This is the posterior synovial joint. And then the most lateral, the most prominent, this is your anterior synovial joint. Anterior synovial joint line you can't see from here. So you can see it from here. So this is the anterior synovial joint line. Anterior synovial joint line is the most lateral. Now, let us see on the you see here this side also, this is your iliac crest line, this is your posterior synovial joint line which is medial, and this is the anterior synovial joint line which is lateral. So the synovial part of the joint is what? This part is the synovial part of the joint. And this part is the fibrous part of the joint. So my target will be here in this part, because in this part, you cannot enter it. So for that, what we will do? We'll do a contralateral oblique. Why contralateral oblique? Because you see, sacral joint is not vertical that we will be doing in the AP. So sacral joint is like this. That means for this side sacral joint, I'm making it oblique on this side, so that these two lines, you see, this line and this line, this is anterior and this is posterior. So they'll be overlapping. And then I'll be going. So you see, CR position is we are making contralateral oblique. And now you see these two joint line will be, you see just what is the change? These two joint line will be overlapped. Picture. Can you appreciate now that this part of the joint is overlapped? First you see this. So this part is overlapped. So anywhere in this part, we can go ahead and we can go in the tunnel vision. You can go. One very important part is that you always remember the iliac crest is covering this part. So you can never enter in this part because iliac crest is covering that. Always remember that you have to be in the inferior part where the iliac bone is not covering the sacroiliac joint. So now we'll be taking a pointer, and like all the lumbosacral procedures, we are not measuring anything, that this much up from the midline, this much of degree of the rotation. All this depends on the image. With a typical image, you have to find it out, and then accordingly you have to go ahead. So you are putting a pointer there, and we are now entering. So
we'll be entering and
in a tunnel vision in the lowermost part of the sacroiliac joint. In tunnel vision. Okay, in the tunnel vision, the needle is entering into the sacroiliac joint. Now we'll be going by the lateral. So what is the CM position? CM we did a contralateral oblique, means right side we are doing, and we are making it oblique towards the left side. So in the lumbar area, we did the ipsilateral oblique, but here you are doing contralateral oblique. Okay, you see? So here one very important part to remember, that the sacroiliac joint is up to here. Today I have posted in the, I hope all of you are the member of the Daradia Fellow Facebook group. Today itself we have done one, the procedure there. And one of our fellows did the procedure very nicely. Dye spread was going very nice. And dye spread was like the pin of the ear. And the needle is, this is not the anterior border of the sacroiliac joint. This is the anterior border of the sacral vertebral body. Anterior, again, this is very important concept to understand. See here, see the anterior, this is the anterior border of the vertebral body, sacral vertebral body. And this is the anterior border of the sacroiliac joint. So anterior border of the sacroiliac joint is anterior than the anterior border of the sacral vertebral body. That means here you see the sacroiliac joint anterior line is this one. This one. Whereas this is the anterior part of the vertebral body. That means normally the needle dye up to here it should be spreading. So your needle tip can be here. Even if you can advance the needle a little more, that is also okay. Because the anterior part of the vertebral sacroiliac joint is like this. Okay, so that is the final needle position. Any question? No question. Okay, so now the last important procedure is your caudal epidural. Look at here again. So caudal epidural is here. We have to find out the hiatus. So these are the cornu. This is coccyx bone. So what we'll do, once we are finding the hiatus, we'll be putting the needle here And then once we are here, we'll be going by the lateral. Okay. So first we are pushing the needle in the AP. Picture and identifying the hiatus. So you see, put a short out, mark short. Picture. You see, this is the sacral hiatus. Okay, inverted U-shaped. Here is the coccyx bone is not there. Imagine the coccyx bone here. And these are the sacral corner. And this part is covered by the sacroaxial ligament. So what we'll do, we'll be putting the needle from here and we'll be touching somewhere in this S5. After you're touching the bone there, then we'll be going by the lateral view. And then we'll be introducing the needle further. So first will be, this is not a tunnel vision procedure. You should be touching that bone there. In the midline. And always remember, the skin crease may not be corresponding to the midline. So that is the needle entry point. And entering through here, needle will be touching this point. Picture. Touching bone. Okay, touching bone there. Once you're touching the bone there within the sacral hiatus. So this is the sacral hiatus, touching the bone there. And now we'll be going by the lateral view. Yes. Okay, so see here, this is the sacral canal. And this is S5, this is 4, this is 3, this is 2. So once we are in the canal, we should be decreasing the angle and then we'll be introducing the needle further. So up to here is your target because this is your S2, this is your S3. So the S2, S3 junction should be the end point. We should not be advancing it further. Why? Because you might be puncturing the dura. Little more. Little more. Okay. So if, okay, now we'll be going, so this much. Even you can advance little more even. Picture. Picture. That is the, no, that much it's not. Picture. This is the maximum point. So now we'll be going AP. Your needle can be on the one side, either right or left. If the patient is having the more right side symptoms, then you can put the needle on the right side, picture. Or if your symptoms is more on the left side, then you can put it on the left side. Sorry. Like here, needle is more towards the left side. So this is okay for the left-sided symptoms. But if the patient is having the bilateral symptoms, then the needle should be in the middle, like this. If the patient is having the bilateral symptoms, the needle should be in the middle. If the patient is having the unilateral symptoms, it's the right side, then you can put it on the right side. Picture on the right side. Or if it is the left side symptoms, then you can put it on the left side. So depending on that, you can further, adjust and reposition the needle, either keep in the midline or you keep it on the affected side. Okay, so this much for the caudal epidural. Any questions?
Hello, sir. I want to ask you a question. Sir,
Yes,
when
yes.
you were performing the ventral rami block, we went through the two foramina from posterior to anterior. I want to
Yes.
ask, where were the meningeal layers or the dura? I mean, the ventral rami block, is it sort of transforaminal epidural? Is it equivalent to that? Sir,
Yes,
a
yes.
little elaborate.
So you see here, the dura is up to here. And our needle is here. So you are not going to puncture the dura if you are not going to medial. It is very difficult to puncture the dura. Okay. And it is also known as it's similar to that of the transforaminal epidural, but not exactly. There is certain difference here because we are entering into the ventral foramina to go into the ventral nerve root. Right? Like if you are seeing it here, the needle should be entering through this dorsal foramina, and the needle should be coming, should not come out of it, should be within this ventral foramen. Understood? It is similar to that of the transforaminal epidural, but exactly not the same. Because transforaminal epidural, we don't have the separately blocking the ventral and dorsal. Basically, we are blocking both the root together, both the rami together, ventral and dorsal rami together. But here, you are specifically blocking because ventral and dorsal together is difficult. And we should not be blocking the dorsal rami. We should be going into the ventral foramina to block the ventral rami. Okay.
Okay, sir. And sir, one question about this caudal block. Like in the pediatric population on the live patients, what the literature say that when we inject the drug or the speed of the drug, it doesn't matter. I mean, the volume matters. So just your expert opinion about it. When we are injecting the dose, should it be injected slowly or it doesn't matter like that?
Give very slowly. Why? Because ultimately the drug is encircling around the dura, and it is going to compress the dura. Rapid epidural is always prohibited because the intrathecal pressure will be rising, and there a lot of reports are there why there is interventricular hemorrhage, retinal hemorrhage because of the rapid epidurals. So rapid epidurals should never ever be given. Always giving very, 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 very slow. And second important part is volume is also important. Suppose if you can remember how much volume is needed for the lumbosacral areas, 1.5 to 2 ml per segment. Suppose you are giving the drug here at the level of the S2-3 junction. So what will happen? If we are giving 4 ml, then 2 ml will go up and 2 ml will be going down, because in the epidural, it will be equally going up and down, right? So suppose your pathology is at the level of the L5S1. So how many segments it is away? Your needle tip is at the level of the S2-3. Then next level is your S1-2. And the next level is your L5S1. So your needle is at the level of the S2-3. So how many segments you are away? You are 2 segments away. That means to cover up to this segment, you need to, so 2 ml is needed here, at least 2 ml, or 2 ml is here, because equally 2 ml will be coming here and 2 ml will be coming here, wasted here. So that means you need how much ml? 8 ml. So the simple formula is for the lumbosacral area, 4 ml per segment. If your needle distance from the pathological area is 2 segments, you need a 8 ml. You can give 9 ml or 10 ml, but don't give 15 ml, 20 ml. If your pathological area is L4-5, then how much volume should be given?
12 ml.
12, very good. So 4 ml per segment. L4-5 means you are 3 segment away. That means 12 ml, or maybe a little more than 12 ml, maybe 12.5 or 13 ml. Don't give a lot of volume there. You give what is needed, because it is the targeted delivery of the drug. You need not be giving too much of volume. So both the things are important. Don't give rapidly. Reports are there for the interventricular hemorrhage as well. And give the proper volume. Don't give too large volume. Okay? Okay, who asked this question? Is it okay?
Yes, sir. Okay. Really thankful, sir.
Sir, one question, sir.
Any other questions?
Sir, one question, please.
Yes, yes.
Sir, if there is pathology at L1, L2 or L2, L3,
Then
can
you
we
should
give
not go with the caudal. Then you should not go with the caudal epidural. Normally, up to L4-5 you go. If you are going into the L3, then you have to give 16 ml. If you are going into the L1, L2, then you have to give 20 ml. So that large volume and very little steroid will be reaching your target, because the other steroid will be wasted where you don't need it. So you go closer to your target. Give transforaminal, give interlaminar there. Okay. For the L4-5 and L5S1, you can go ahead with the caudal epidural.
Okay, sir. Thank you.
Okay. Okay, so if no more question, then good night for today. Go to the recording again. And both this back pain 1, back pain 2, back pain 3 modules are extremely important. I'll be telling all of you to go again and again, try to understand exactly, because most of you are anesthesiologists, and what is we are lacking that we don't deal and examine the patient directly. So you have to examine the patient directly, and for that, you must be having a good knowledge about how to go ahead, what are the steps, and how to go ahead with the, the order, the different conditions, the pathophysiology or the clinical features, and never, ever rely on MRI reports. You see the MRI reports at the end. First you do a clinical evaluation and then you take a decision. Okay. So, thank you,
Sir, yeah, excuse
answering
me,
all-
sir.
Yes.
Sir, just for the knowledge, when we are examining like the musculoskeletal component, if a few persons are patient, they might have multiple pathologies like the peripheral muscular dystrophies, and then still having the certain skeleton deformity or any nerve injury. So how
Yes.
we would be in those cases? I mean, muscular atrophy or loss of the girth due to dystrophy or misuse of the muscle, chronic problem, and superimposed another issue.
There is no difference. The same way, because here also we are doing all the inspection, palpation, range of movement. That is your muscle strength, because in the motor we are doing the muscle strength examination as well. So the same thing is important. Here, basically, some part of the clinical examination part is you are lacking. Here is auscultation, the percussions. So these are sometimes percussion is also needed. Deep percussion is sometimes needed in the vertebral fracture, or sometimes in the that is a special test. Otherwise the percussion is do not come in the routine clinical examinations. So the muscular pathology.
Sir, one question.
There is some of the muscle pathologies, myositis, very rare, but still myositis can be an important cause of the pain. It is an autoimmune disease and can cause the cause of the pain.
Sir, if we have a target, our target is L3, L4. Can we pass the epidural catheter through the
Yes, we can.
epidural needle, and we can go there?
Let me tell you. First of all, that normal epidural catheter, you cannot guide it. You cannot steer it. It might be coiling anywhere, and you don't know exactly where it is coiling, because it is a non-opaque. So if you are trying to use a catheter, it's extremely good, but you should be having a radio-opaque catheter. We call it RAX catheter. So normally we are not covering it here, we cover it in the advanced course. But RAX catheter is very costly and that is not commonly done. So RAX catheter is a radio-opaque catheter. You can steer to your desired level. With a caudal epidural, you can go at the level of the L2, 3, L1, L2, even the thoracic areas, even the sacral areas also you can go. Because this catheter is too long. You can thread it up to the sacral, cervical areas. But ordinary catheter, what we are using routinely in the anesthesia practice, that is not recommended. Because that is not radio-opaque. That can coil anywhere. You cannot steer that catheter. The RAX catheter, you can steer it to your desired place. You can go to the right side, you can go to the left side, you can go to any segment according to your choice. So that is the choice. Okay?
Okay, sir. Thank you.
Okay.
And sir, one more question about all these interventions, the coagulation profile status, please. I mean, that is must.
Not a very important contraindication. So few investigations should be always done. One is your routine investigations to rule out the infections. Systemic infection is a contraindication. History is very important to understand that there is no fever, no cough, all those things. And uncontrolled diabetes is a contraindication. Anticoagulant drug is similar kind of recommendations for the regional anesthesia. That means aspirin 75 milligram is okay. If aspirin is 150 or higher, or if there is a clopidogrel or higher anticoagulant, that must be stopped. So these are the same recommendation for the regional anesthesia technique. Okay.
Hello, sir. For discogenic pain, is there any particular test for diagnosis? Or is it clinically?
Yes. Basically, what I feel, in our book also I have written that no clinical test, no clinical sign is a sign for the discogenic pain. If you're doing everything, everything will be becoming normal. And very rarely you can get two things. One is flexion can sometimes cause pain, and sometimes local tenderness over the interspinous ligament. Why? Because your disc, when the internal disc reception is there, the two vertebral bodies come closer. The two vertebral bodies comes closer, the two spinous muscles will be stressed. So the interspinous ligament will be, the stressed, and there might be pain in the midline. But that is the rare findings. Most of the times, you will not be getting any findings. And if you are not getting any findings, you suspect that internal disc disruption first.
Okay,
Okay?
sir. And how to treat it, sir?
How to treat it? Internal disc disruption treatment is very difficult. But medical normally the conservative management with the duloxetine, with this all those things. If you are talking about the interventions, the few interventions are evidence-based for that. One is your simple caudal epidural. How it works? Because the discogenic back pain radiates through the sympathetic fibers. So when you're doing the caudal epidural, we are also blocking the sympathetic fibers. So that is how it works. But the best procedure for the internal disc disruption is biacoplasty. But that is beyond the scope of this basic course. So caudal epidural can be done for a short-term relief. Long-term relief, biacoplasty. But again, those are rarely needed. And most of the patients do good with the conservative management, with the medications and the back exercise program. Okay?
Okay, sir. Thank you.
Okay, so good night and thank you, series, for continuously answering all the questions in the chat box. I'm
Yes,
sure
sir.
all the participants are getting benefited for that. And again, as I told you in the first class itself, that never hesitate to contact Dr. Series, Dr. Suspa, Dr. Hori, Dr. Milton. We all are there. If you are having any question anytime, you can directly text all our faculties, and we are there to answer your question. It's not just you have to ask the question live. Sometimes what happens, sometimes I have seen fellows hesitate. Sir, I asked this question, people will be thinking it's a foolish question. But I always tell no question is a foolish question. In your journey, a lot of questions might be coming. Always feel free to ask us live, so that other persons who are having the same questions will be benefited from that. Or if you still are hesitating, then personally text all of us, will be there. Okay? So good night for today.
Thank you, sir.
Good night, sir.
Thank you, sir. Good night, sir.
Good night.